Okay, we have a packed agenda, so I'm going to get started. My name is Rebecca Wallach. I'm the director of the Evelyn Frank Legal Resources Program at NILAG. We're so excited to have you here today for the first part of a two-part webinar series, Demystifying Access to Medicaid Home Care. Today is the first part, and we're going to be focused on an introduction on how to access Medicaid long-term care services. And we are joined today by two great attorneys in our unit, Peter Trevitsky, supervising attorney, and Wenru Chen, staff attorney and Borchard fellow. I will be passing it over to Peter now, and welcome everybody. We're glad to have you here.
All right, here we go. Welcome everybody. Thank you for joining us. Some table setting. Um, well, everybody but me right now should be on mute. You can post questions as we go in the Q&A. Please don't put them in the chat if you can avoid it. And we'll be stopping periodically to see what what questions people have. We'll also be sending out a copy of the slides and a recording to everyone who registered. And, of course, you're welcome to share the materials with others. Um, so NILAG, New York Legal Assistance Group, is a uh, nonprofit civil legal services law firm, which is pretty much everything you can think of except like criminal law and torts. We have a litigation team. We have a public benefits unit, an immigration practice, a tenants' rights practice. I think one of the biggest medical legal partnerships in the country, legal health. Um, Practice working with the LGBTQ community, a consumer protection unit, a foreclosure prevention unit. We do financial counseling. We do a lot. Um, we also engage in policy advocacy efforts to help people experiencing poverty. And every now and then we do litigate bigger cases. Those of you who have attended one of our webinars in the past might know that we litigated the transition of the consumer-directed personal assistance program to a single fiscal intermediary, the Anguster litigation, this time last year. The Evelyn Frank Legal Resources Program, which is our unit, has been around for a long time. Previously, it's self-help, but community services, but we moved to NILAG. I think it was 2012 or 2013. We've always focused on helping folks with disabilities and older adults access healthcare and home care to uh, remain in the community as independently as possible. We counsel consumers on Medicaid, Medicare, home care eligibility. We we give trainings like this to professionals, to families, to caregivers, to consumers about changes happening in healthcare programs and how to best serve uh, the populations that we serve. We we represent folks in appeals when the local Department of Social Services or a health plan tries to deny services that are medically necessary or reduce services. Uh, we also handle Medicaid eligibility hearings as well as the Medicare Savings Program. And of course, what we're all here to talk about, we help folks access Medicaid home care, particularly through managed long-term care plans. In addition to all of that, we run a website that I hope everybody has bookmarked. If you don't, please do. I think Rebecca is going to be dropping the link in the chat for everybody. Uh, Public health insurance programs are vast, and they do a lot, and they are governed through federal and state law, sub-regulatory guidance, uh, policy manuals, directives. Sometimes all we have is a PowerPoint. And it's kind of all over the place. And this is our effort to organize it in a way that is more accessible to everybody, advocates, consumers. We do have some consumer-facing materials on there, and it's a labor of love that we're constantly working to update. So I hope that you make great use of it. Um, and then finally, before I go into the formal agenda, this is part one of a two-part series. You can sign up to register for part two, which will be in June, at the link on the slide. We also hope you'll sign up and to join our newsletter, which goes out periodically. We will not clutter your inbox. I think we send out maybe 3 a year, usually with updates, webinar offerings like this one, um, and other news. All right, so today uh, we are talking about everything leading up to getting home care, right? And then the part two of the webinar is going to be getting more home care or fending off a reduction of home care, more navigation once you actually have the services. Um, all right, so I'm gonna talk briefly, well, not so briefly, but I'm gonna give you an overview, and then I'm gonna hand it off to Wenru to talk about the Independent Assessor Program, and then I'm going to come back and talk to you about immediate need. Okay, and we're going with a Wizard of Oz motif today. Just, the um, the imagery of traveling down the yellow brick road, I think, is pretty helpful. Some of my colleagues have heard me use it in and around the office. Um, so, and then, of course, the Emerald City will be getting home care. Uh, the, Broadly, the steps to getting Medicaid home care are first establishing that you have financial eligibility for Medicaid. In other words, you need the coverage to get the services that you want. Uh, the next step is to determine your eligibility for home care, and that's going to be the New York Independent Assessor Program that Wenru is going to talk about. And then finally, you get authorized for home care services. And we're largely going to be living at the nexus of these last two bricks. But first, I'm going to talk to you a little bit about financial eligibility. This is not going to be a nuts and bolts Medicaid application review, but there are some principles that will be helpful for uh, sort of getting started in the process. And then, like I said, Wenru is going to talk more about the Independent Assessor Program in depth. This slide is sort of a zoom out of the previous slide. I honestly just couldn't choose between them. Um, so the basic steps are apply for Medicaid. Again, that's financial eligibility. Then get approved for home care. That is the independent assessor. And then you access services either through a plan or the Department of Social Services. On the apply for Medicaid front, like I said, we're not going into nuts and bolts. And I think this is probably one of two difficult slides that I'll be talking about, but I'm going to try to simplify it for you. So the Medicaid program sorts people into a category. Uh, and category matters for three reasons when it comes to accessing home care, at least three that I could think of. One, where your case likely lives is usually directly related to your category. That's slowly changing, which I'll get to, but uh, that can be a clue to where your case lives. The second reason it matters is that it gives you a sense of whether you're already in a plan, which then tells you what you need to do to get home care. And uh, the third reason that it matters is it tells you whether you need to investigate the case before you seek home care. Um, and that'll make more sense in the next slide or the next two slides, but I'm going to come back to those points. So what do I even mean by category? A category is a bucket. The Medicaid program sorts you, and your category tells you what financial criteria you need to meet either to get coverage or preserve your coverage. Uh, before the Affordable Care Act, the Medicaid program had, in a sense, I guess, different priorities in what populations were focused on, like kids, pregnant women, folks with disabilities and older adults, cancer patients, childless couples, and unmarried individuals were basically shut out unless they fit into one of those other larger one of those other many other categories. It was much more of a patchwork in that way. And in creating the Magi group, the Affordable Care Act made it easier for lower income singles and childless couples to access Medicaid, along with everybody else that was already covered, and kept the pathways for older adults and people with disabilities. So now um, you've got a Magi group, which is folks who are under 65 without Medicare, and um, anyone who qualifies for Magi Medicaid in New York who does not have Medicare. So again, this is the bucket on the left. Younger, largely non-disabled folks, but definitely without Medicare. Um, those folks should automatically be in a managed care plan. And this is what I was saying before, that it matters uh, if you know that you have Magi Medicaid, because then you're most likely in a plan, and then you can just skip to the independent assessor. Um, and also, a common question that we get is, do these folks need to document their assets? Because there's a lot of misinformation out there. But no, if somebody has Magi Medicaid and they're in a plan, they can go straight to the independent assessor to be evaluated for home care. By contrast, the non-Magi population, which is probably the majority of folks applying for home care, those are going to be people who are 65 and older or under 65 and disabled with Medicare. And then there's this third group that have a choice of which budgeting option they want. So really, I think the point of this slide is like if somebody's Magi, you know that they can kind of move ahead. If somebody's non-Magi, we need to do a little bit more digging. And the first question to ask is where are they going to apply, right? Um, because one of the other things that happened under the Affordable Care Act is we've got now two eligibility systems. New York State of Health operates one of them, and the local departments of social services operate another one. In New York City, that's the Human Resources Administration. Uh, it used to be that the New York State of Health only handled Magi cases. That, I said before, where you apply for Medicaid is slowly changing. This is what I was talking about. So New York State is undergoing a several years long effort to make it possible for everybody to eventually apply at New York State of Health, including the over 65 disabled Medicare population, the non-Magi folks. But it's going to take a while. And the reason that that matters for us is if you already have Medicaid, uh, and you do not have a Medicaid spend down, I'm not going to define that because it's a we really want to cover today. But if you just have straight up Medicaid with where financially you qualify below the Medicaid limit, free and clear, without any special tricks, fancy budgeting, pooled trusts, none of that, then you can get your Medicaid through New York State of Health now. And I think Rebecca's going to put in the chat our article on this. it is at New York State of Health. It is called the Medicaid Eligibility and Client Management System, MECM or MECM. Um, but to the consumer, there is no distinction. Like everything public facing will say New York State of Health. So uh, then the question becomes, well, do I apply for home care at New York State of Health or do I go to HRA? Because it looks these kind of look the same, right? You've got both groups can now apply, but actually no. Non-Magi folks will not be able to get home care at New York State of Health for at least a few years. Until then, they, yeah, if you have a case at New York State of Health and you want to get home care and you are non-Magi, then you need to move to the Department of Social Services. Whereas if you are Magi at New York State of Health and need home care, you can go to NIAP, the independent assessor directly, and then get your services from the plan that you are likely already in. Um, okay, so all right. I've figured out that I am non-Magi and my case is not at New York State of Health. How do I know if I have enough coverage to then get home care? So, um, many of you, I just, I looked at the RSVP list and I recognize many of your names. So glad you could join us, of course. But um, th those of you who are still pretty new in the game, when you look at the Medicaid application, it's two parts. And one part is all demographic information and income. And the other part is where you would prove what your assets are. So the big difference between financial eligibility when you're Magi versus non-Magi is that if you're a non-Magi, there is an asset limit, whereas for Magi, there is not. So for non-Magi, we need to see what you have in the bank, right? Um, and the way to document it, well, before I even say document, I should say on the supplement A, which is the supplement form to apply for non-Magi Medicaid, page 3, there is a summary right there when you apply of the different levels of Medicaid. And the first level is no home care. And for that, you just need to attest to what you have in the bank. You still need to fill out the form, but you don't need to include any bank statements, right? You just say what you have in the bank. For the next level of coverage, which is home care, you have to verify your resources at the end of the previous month or the first of this month. And then the next level after that is nursing home coverage, for which you would prove what you have in the bank plus 5 years of bank statements to show that you didn't transfer assets. So the type of coverage you get is directly correlated to what your burden of document production is. Do you have to prove what you have in the bank? If so, how much proof do you have to provide? And if you have documented your assets, that should be stored somewhere in the Medicaid program. But uh, we haven't gotten to the point where the Medicaid program is sending out explanations of benefits, right? So, once you have Medicaid, you may not have any idea what level of coverage you have. And um, the public health emergency, which was a very weird time for Medicaid all around, also gave rise to this phenomenon where many people were able to attest to having, um, a certain amount of assets in the bank, but they were never required to prove it. And then they may have gotten home care that way. This was perfectly allowed. There's no foul play here, but it is catching up because now people need to be redetermined. Um, so you might weirdly stumble upon somebody who is getting home care, but never actually documented their assets. And how could you possibly know that? So in New York City, the Human Resources Administration has a few ways that you can discover that information. If you find out that somebody has not documented their assets, then you would need to make sure that prior to pursuing the independent assessor, they complete a supplement A and they document what they have in the bank to get their coverage upgraded. And then you can go and get evaluated for home care. So a really great way is to look directly at the Medicaid renewal. You wouldn't know this because I don't know why they do it this way, but there's a code right there on the renewal, RVI code 2. That means that you have documented your assets. RVI is Resource Verification Indicator. It's right there in the name. Resources is the term that Medicaid uses, excuse me, for assets, right? So did this person verify their resources? Resource verification indicator. Another great way is the automated line. I'm going in reverse, but the automated line that HRA offers uh, should tell you all the coverage that or rather, all of the services that are covered under the type of Medicaid that you have. Uh, it's not my favorite method, though. If anybody's ever tried to use it, it it's just you know what I'm talking about. Like there's a point where it seems like the message is over. Like you go through the automated system, you put in your info, there's a recorded message pulling information directly from your case, and then you think that's all there is to say. And then I forget if there's just a long pause or there's a prompt, probably a prompt, where they ask if you want to hear more. And then you have to press that to then hear additional information. Um, like if your renewal is in process. So it's not perfect, but at least it gets you the information quickly without having to wait on hold for an interminable amount of time. Uh, another way to know is if your case is in the home care services program. I don't think this is true outside of New York City, but in New York City, the Human Resources Administration has many departments. And if you're a dual eligible who needs home care, your Medicaid case would live there. They would handle processing of your financial eligibility to preserve your coverage, including processing your renewal. And then, so like on this renewal on the right, it says location CED surplus. I forget what CED stands for, but surplus is a unit. That is not the home care services program. And then the last point, or the first point really, as I said before, people who have Medicaid only would already be in a health plan and can skip ahead to uh, um, the the independent assessor. Okay, now we're moving on to the next brick in the yellow brick road, which is to get approved for home care. Um, and I think most people have heard of prior authorization or prior approval if they have health insurance. But if you have no idea what that term means, it literally just means asking permission from the insurance to get a service that you need. Your doctor would probably take care of that for you um, if you're seeking something that requires it. Health insurance companies have different rules about what they need prior authorization for. Usually it's stuff that's very expensive. And public health insurance programs are have adopted that same strategy where you have to get permission first. Um, the and I think it's helpful to think of the independent assessor program as the Medicaid program's answer to prior authorization, specifically for home care. But sorry, it's only part of the prior authorization process because that is the that is just a determination of eligibility. decision about how many hours you get is left up to the health plan that you ultimately enroll in, or the health plan that you're already in, or the Department of Social Services. The independent assessor consists of two parts, which Wenru is going to talk about in greater detail. But they are the community health assessment, which is the same assessment that all of the plans are required to use when they evaluate somebody's service eligibility, uh, along with a clinical appointment, where they're primarily looking at whether the patient is medically stable and I think self-directing. But we'll hear that from Wenru. So okay, and then when the assessments are done, you receive an outcome notice where you find out whether you are eligible to access services and or enroll in a health plan, an MLTC plan specifically. Uh, okay. I'm sorry, the majority of this presentation is going to focus on MLTC enrollment. Um, But remember, not everyone who goes through the independent assessor is going to be seeking services through an MLTC, and some actually can't. We'll talk about that in the next section. Some people have to go directly to the Department of Social Services for home care. But we're mostly concerned about CDPAP, the Consumer Directed Personal Assistance Program, and personal care services, which I'll define in just a minute. Okay, and then the final brick in the yellow brick road is to access the services. And again, um, if you are a Magi consumer, you are most likely going to be in a mainstream managed care plan. They would be the plan you're in would be the plan that would determine rather how many hours of service you get, and they would contract with a home care agency and staff the case. And then for the non-Magi folks, uh, they would go to an MLTC plan, a managed long-term care plan, or they would go to the Department of Social Services for their home care. All right, so I said before I would define these. Personal care is probably the most common. This is when an aide comes to help you with activities of daily living, including bathing and hygiene, walking, toileting, transferring, eating, and housekeeping. Uh, it is paid for, well, it's staffed by a home care agency, and the home care agency gets paid by the local Department of Social Services or the plan that you are in. The Consumer Directed Personal Assistance Program is uh, very much, well, very similar in that the aide uh, would come to your home to help you with activities of daily living. But there are a few important distinctions. One, you are responsible for staffing. You have to find your own aides. Your aides can also number two, your aides can also do skilled tasks, so it's not limited to activities of daily living. Um, and number three, uh, th- I mentioned the Engesser litigation at the start of this. Uh, the that was about the state's transition from I don't know, it was like 500 or 600 uh, what are called fiscal intermediaries to one. That single fiscal intermediary is called uh, Public Partnerships LLC, PPL. Um, and that transition was messy. I still hear lots of complaints about PPL, uh, two this week alone, actually. Um, and a fiscal intermediary is kind of the same as a home care agency in personal care, except that they are again, not responsible for staffing because you are when you're in the CDPAP program, but they handle the payroll. So I mean, it's in the name, fiscal intermediary. They're the intermediary between the health plan or the Department of Social Services and the consumer. There was a question in the registration about who can be the aide in the CDPAP program. Thank you for that question. Um, and it's pretty broad now. I think it's pretty much anybody that you're not married to can be the aide. I may be overstating that, but it is pretty broad. I would be curious when we get to Q&A if that person has a very specific scenario in mind, because there was also some guidance released a couple of years ago about when the aide is also guardian or power of attorney, and there's always some weird scenario that we're hearing about. So I'd be curious to hear that question if it can be made more specific. Speaking of which, Rebecca, do we have any questions about all of that?
Hi, Peter. I've been answering a lot of great questions in the Q&A. There's one here. How many months or years of resources need to be provided with the supplement A for long-term care, not for nursing home care?
It's just 1 month. But I was a many of you know that I was a social worker before I became a lawyer, and I remember this question asking it myself. There is a myth that it needs to be 3 months. Um, that that comes from people who are seeking retroactive coverage, which I don't know that a lot of people are. But yeah, so that's the long version. The short version is 1 month.
Very good. And then just to clarify a little bit on who can be the aide to add to your statement, Peter, parents cannot be aides of minor children. And if someone needs a designated representative, that designated representative could not be the PA. So it is more complicated, but it is very broad. I agree with you in New York State. And just based on the questions that we've seen, we're hoping to do a separate webinar on CDPAP in the future. So that's it, Peter. I will turn it back to you.
Right. And thank you. I don't know how I forgot those two. We don't work with a lot of minor children though, so that one I think is really easy to forget. Uh, okay, so different pathways. This did not actually happen in the Wizard of Oz, as far as I know. I made this with AI, but um, once you are ready to go, where do you go? Um, and what is the goal, right? What does the Emerald City look like? So first, um, long-term services and supports uh, at this point are mostly administered by managed care. I keep saying that uh, someone might be getting services through the Department of Social Services, and that is true. But um, more and more over the years, um, the the way the ability to get services from the Department of Social Services, those doors have been slowly closing. Um, there are many more people who are now required to be in a managed care plan. And there's also many people who might actually want to be in managed care because, for instance, the provider networks might be a little better. We've heard that anecdotally. Um, and it may also be, I mean, not that you wouldn't have to do it without a fight, but it may also be easier to get some things like environmental modifications. Um, but there are five plan options, and whether you can enroll in them depends on a few um, a few things that are not entirely related to the the real topic that we're talking about today, but it is worth knowing. So most folks are an MLTC, managed long-term care. Um, and you can see that as of March, that number is approaching 300,000 people. Most enrollees will also have Medicare, but their their Medicare has nothing to do with their home care. Medicare would be paying for primary care, and that's probably why it's so popular because um, of of the three options on here that are directly for folks who have Medicare and Medicaid, this is the only one where the plan does not assume responsibility for your primary care. In other words, if you enroll, if you're new to need, if you're a dual eligible, a Medicare, Medicaid beneficiary, and you need home care, uh, enrolling in an MLTC plan is the only option on here where you might not have to potentially change all of your doctors or some of them. The next one on the list is PACE, Program of All-Inclusive Care for the Elderly. There are currently only two operating in New York City. I think they may be more popular outside of New York City, but we are going to start seeing more of them due to, well, I don't, there was a change in the law, I believe, but I'm less familiar with that. I know that the state put it on a PowerPoint where all of these plans were applying to operate a PACE program in New York City. So that number is closer to 10,000. Then the Medicaid Advantage Plus plan, which has been growing, that number is approaching 80,000. And the reason that number is growing is that people who are becoming dual eligibles, who already have home care, are now subject to a requirement that um, if they, well, they have to choose when they become a dual eligible, they have to choose if they want to go into MLTC or if they would be willing to just be enrolled passively into uh, the Medicaid Advantage Plus program. That I think that started, I think that passive enrollment started right in it was either spring of 2020 or January of 2021. It was like right, I think it was like pre-vaccine, like right when when vaccines were first starting to roll out for COVID. Um, but uh, so those numbers have grown, I think, largely because of that. Um, and then the last two options are for people who, I'm sorry, I should also say PACE and Medicaid Advantage Plus. A common question, what is the difference between these two? PACE, you would get all of your services from a single site, like you would go to a specific place, whereas Medicaid Advantage Plus is closer to what we would normally think of as for health insurance. Um, okay, now mainstream managed care and HARP, health and recovery plans. These are both options for people who do not have Medicare. Um, I think so I said before that if you were a Magi Medicaid recipient, you were most likely already in a plan. This is that mainstream manager. This is what I was talking about. So I think there's like millions of people in this type of plan across the state. Health and recovery plans are um, invite only for people who are higher users of behavioral health. But both of those options do offer home care. And the last thing I'll say about this slide is that PACE, you have to be at least 55, 55. Um, the other plans for Medicare, Medicaid recipients don't have that restriction. Okay. So once you're in a plan, uh, there's a bundle of benefits that you should have access to. There are four types of home care. I think there was a question pre-registration of about the other a pre-regist I'm sorry, a registration question about what the other types of home care are. Um, the, there are four: personal care and consumer-directed personal assistance. I've already talked about. There's also certified home health aid, and there's also private duty nursing. And basically, the services are in the order they're in because as you progress down the list, the aide can do a little bit more. So a personal care aide can do ADL work. Home health aides can do slightly more skilled tasks. Um, I'm gonna jump ahead because I just realized I'm already at 40 minutes. Boy. Okay. Um, yeah. Okay. Primary care is covered under Medicare. Moving on. The pathways to getting home care are um, a little tricky. This slide is geared toward dual eligibles. The vast majority of home care seekers, as I said, probably are dual eligibles, but of course not all. Um, the and most of our clients are going to be in the first column. They're dual eligibles with full Medicaid, and there the independent assessor wants to see if you have a need for home care for more than 120 days. Um, and then, but you can also apply for services through the immediate need option. Then there's a group of folks for whom enrolling in a managed long-term care plan uh, is optional. Uh, these are going to be younger dual eligibles who are 18 to 20, or people who are um, over 18, but they do not have Medicare. Um, this also, this relatedly um, lines up with the people who have a choice between Magi and non-Magi Medicaid. And then finally, there's a group that can't enroll in MLTC at all. These are largely going to be people who are in a waiver or home hospice. Um, for home hospice, though, you actually have to call New York Medicaid Choice and make sure that they know that. Otherwise, you might be swept into a managed care plan. So, in the interest of time, I'm not going to read this to you all, but the three travelers with you down the Yellow Brick Road, each one of these lines up to with one of the scenarios on the previous slide. So the Tin Man is somebody who is excluded. The Scarecrow, the Cowardly Lion is somebody who has the option of enrolling in MLTC, and the Scarecrow is someone who must enroll in MLTC. Okay. And now we're at the gatekeeper. So I don't know if I should just hand it off to Wenru or if there are any questions that you think I should answer now, Rebecca.
I think we should pass it up to Wenru.
Okay. All right. Go ahead.
Thanks, Peter. All right. So we're going to be focusing for the next couple of minutes or so on the New York Independent Assessor, which is, as Peter said, is really the gatekeeper for people who are seeking home care for the first time now. Next slide, Peter, please. So the New York Independent Assessor Program rolled out in phases since 2022. Is the New York Independent Assessor is who's going to assess Medicaid recipients over the age of 18 who are seeking home care to determine whether they're eligible to enroll in a managed long-term care plan. That's the MLTC plans that most of the clients we work with are probably seeking to be enrolled in. This is the Scarecrow example, the age 70 and has Medicare example from Peter's previous slide. Or, eligibility to receive personal care, consumer-directed personal assistance from the local DSS. That's HRA, Human Resources Administration here in New York City. That's if they're exempt from MLTC. This process of getting home care from the local Department of Social Services, HRA in New York City, is also what you would get through the immediate need process, which we'll talk about, or Peter will return back to at the very end. That's that Tin Man example in Peter's great slide. This is the 19-year-old who's in a waiver. And then we have the other scenario, someone who's the eligibility to receive PCS, consumer-directed personal assistance from a mainstream Medicaid managed care plan. This is for those who don't have Medicare or other third-party health insurance. And this would be the Cowardly Lion example, a 40-year-old with a disability, but no Medicare. NIA is run by Maximus as a contractor through the DOH. Sorry, I can't see the full thing. All right, so the standard NIA process for MLTC enrollment, or even for any of those categories that we talked about in the previous slide, the consumer is going to call that 855 number Monday to Friday, even Saturday. You're going to schedule 2 assessments. That community health assessment is the first one. That's the long one, and the one we probably most think about with in terms of it's the one that produces the uniform assessment, the UAS. It's going to take a couple of hours. That's the one where the nurse assessor comes and asks a lot of really detailed questions about the help that the consumer receives with their activities of daily living. The second appointment is a clinical appointment, and that one is, let's see here, with the NIAP, York Independent Assessor website says it's a medical exam. It's conducted by a clinician, and they'll ask about your medical history, the medical care you're getting now. And so it's much more focused on medical care, which is why I think Peter was relating it to whether you're medically stable. It's a lot more medically focused rather than the community health assessment, the CHA, which is more about your activities of daily living, your functional capacities. Both the CHA and the clinical appointment should be scheduled within 14 calendar days of the call. The consumer has a choice to choose in-person or telehealth. And, we want to emphasize that consumers have the right to ask for in-person, understanding, obviously, sometimes people don't want in-person, whether it is just concerns about, communicable, like the flu, right? And things that get passed along when bringing new people in. And so there might be reasons where people don't want to have an in-person assessment, but the pros of an in-person assessment are that, sometimes it's a little bit better to convey to the nurse assessor for the CHA that person's functional needs when it's in person rather than telehealth. So it's kind of a personal balancing, and the consumer needs to be aware, though, they should be aware that they have the right to ask for an in-person assessment. Next slide, please. Here are some phone numbers as well as emails to make complaints to DOH. DOH is the Department of Health. We're talking about the State Department of Health, not the City Department of Health, about NIAP. You should send it to both this independent assessor email as well as the appropriate Department of Health complaint unit. We definitely recommend sending complaints, even if you think it won't do anything. As Valerie Bogart, our former director, says, the state doesn't know about trends and doesn't know about complaints unless we make them. And so complaints are certainly something that if you have a complaint, we encourage you to reach out there. These emails and phone numbers are there for a reason. They can't know about things not happening or going wrong, or, rules not being followed if people aren't complaining about them. Next slide, please. So here we're start talking, really mainly focusing not on the clinical assessment, because that's about your sort of medical needs and the doctor, but we're focusing really for the bulk of the NIA presentation today. It's on that CHA, the community health assessment by the nurse assessor, where they go through your activities of daily living, as well as instrumental activities of daily living and what help is needed with those. So starting last year in September, there is a ADL. ADL stands for Activity of Daily Living. There's a minimum number of ADLs that applicants must show through the independent assessor process that they need either limited physical assistance with, if they do not have a dementia or Alzheimer's disease diagnosis, or cueing or supervisory assistance with if they do have dementia and Alzheimer's disease. So you can see there's quite a big difference, which is really important to keep in mind. If the consumer does have a dementia or Alzheimer's disease diagnosis, they need to have a specific form filled out by their doctor, and this needs to be submitted before the assessment. So, when you make the call, you can mention it to schedule the assessments. You can mention it, and there's a fax that you can send that form to, because if you don't have this form submitted, then the consumer has to show they need limited physical assistance with at least 3 ADLs. But with the Alzheimer's or dementia disease diagnosis form, they only need to show cueing or supervisory assistance with at least 2 ADLs. This new minimum that started in September last year eliminates standalone housekeeping services. So some of you may remember previously, if someone was not able to meet an ADL requirement, but they needed housekeeping, like housekeeping tasks. So that would be laundry, shopping, groceries, all of the IADLs. They used to be able to get maximum 8 hours a week of housekeeping, standalone housekeeping services. This is no longer a possibility. All right. Next slide, please. So here is a list of activities of daily living that count towards the 2 or 3 ADL required minimum for the current NIAP assessment. So you can see that it includes bathing, personal hygiene, upper body dressing, lower body dressing. These are separate ADLs, upper body and lower body. So you do want to also be specific, counseling a client or the consumer themselves to be aware that they should be talking about these separately. There are different functional needs for upper body versus lower body dressing, walking, locomotion, transferring, toileting, bed mobility, and eating. And eating also is very specific. It's about the actual eating. Sometimes eating gets put together with cooking and prep, and cooking is an IADL that's separate from eating. We're talking about the actual function of eating, like bringing a spoon or a fork to the mouth to eat. So what ADL score, therefore, is needed? There are 7 different degrees of assistance in the CHA, the Community Health Assessment. You go from independent setup help only, all the way to total dependence, where it's full performance by others during all episodes. So the ones that really matter, the kind of threshold, is at number 4 for people who do not have a dementia or Alzheimer's disease diagnosis. They need to show at least limited assistance with at least 3 ADLs. So that's guided maneuvering of limbs, physical guidance without taking weight. It also includes contact guarding or hovering. So, if somebody has more extensive assistance needs, like the extensive assistance, maximum assistance, anything that's weight bearing, you definitely want to emphasize that, but you need at least this limited assistance. Now, for somebody who has a dementia or Alzheimer's diagnosis, then they only need to show that they need assistance with 2 ADLs and only at the number 3, supervision or oversight cueing level. So it is quite different, and it can really make a difference, again, if they do have a dementia or Alzheimer's diagnosis, or if that is a suspicion on the part of the family members, and it's really important to get a doctor involved in order to complete that form if it's true. Okay, next slide, please. So what about help with housekeeping tasks, or otherwise known as instrumental activities of daily living? Instrumental ADLs do not count at all for eligibility for services. The nurse assessor is still going to go through them. They're still going to ask about meal prep, laundry, other housework, shopping. But the problem is, if that's all you need help with, you're not going to get an outcome letter that finds you eligible to enroll in a MLTC or otherwise for home care. If you do meet the ADL test, obviously you will be able to receive help with your IADLs. But if you don't meet the ADL test and all you need help with is an IADL, the consumer, they're not going to be able to get just solely that help for IADLs. Next slide, please. So this is an example of an outcome notice. And I don't know how many of y'all have seen an outcome notice. They're very confusing. So it's important to read it thoroughly and carefully, all of the pages, because in order to be eligible for MLTC, you need to both show that you're passing the ADL test, either the 2 or 3 minimum, depending on whether there is whether the dementia and Alzheimer's disease diagnosis form has been filled out, And you also need to show that you need ADL assistance for more than 120 days. An unfavorable outcome notice does not break down, which test they failed or how many ADL short they are. So it is really confusing. Just going to pull up an example of the language of one that we've helped with, where it says you are not eligible and you don't need help with more than 2 activities of daily living. And so you're saying, well, wait, isn't the requirement 3? Well, yeah, the language is really, really confusing. And so it's important to read really carefully. Next slide, please. If you're found eligible for MLTC enrollment, the outcome notice should say whether the consumer is, let's say you're eligible, first of all, the consumer is eligible. And it'll also say whether the consumer is medically stable, and whether for voluntary MLTC enrollees, this is ages 18 to 21 and adults without Medicare. It also will say whether the consumer was determined to have a nursing facility level of care score of over 5, because that's required for MLTC enrollment. If the outcome notice says MLTC enrollment is denied, or you're not found eligible, the consumer has fair hearing rights to appeal against NIAP. But you can no longer seek again to have standalone that housekeeping help with IADLs from the local DSS if the consumer fails the ADL test, unless, and we'll get to this in a couple of slides, they have service legacy status. So it's unclear if one could seek short-term, PCS or CDPAP home care from the local DSS or HRA if one passed the ADL test but did not need the community-based long-term care for more than 120 days. It's unclear with us. And so certainly if that's your situation, we invite you to encourage you to reach out to us, for further investigation. Next slide, please. For NIAP outcome notices that say the consumer is not eligible, they may also mention eligibility to enroll in a PACE plan. So Peter had covered PACE plans before. They are very rare in the city, but if you live in a neighborhood where there is a PACE plan, maybe that is an option you want to explore. PACE stands for Program of All-Inclusive Care for the Elderly. It combines Medicare, Medicaid, and long-term care services in one plan. If you join a PACE, though, again, that hallmark of it is that you're going to a center in your neighborhood to get almost all of your care. To be eligible for PACE, the applicant has to be over 55 and have an NFLOC, that nursing facility level of care score of over 5. The NFLOC score, I'm sorry if I didn't mention it previously, the NFLOC score is calculated based on the level of assistance you need with your ADLs from that uniform assessment, from the CHA. So those two things are kind of related. Next slide. So if the NIAP outcome says, consumer, you are eligible, great. Well, now you think, what's the next step? It's not as straightforward as you may think. For MLTC enrollment, you pick the MLTC, the MAP, which is the Medicaid Advantage Plus plan. Here, we're not talking about a Medicare Advantage plan. Those are 2 completely different things. Or a PACE type plan. The plans will conduct their own mini social assessment and offer of plan of care or, an hours authorization. You do want to be mindful of the timing of when you're doing this, because enrollment in MLTC has to be completely in. So not just you signed it or the consumer signed it, but that it was fully submitted to Maximus and the state and everything's fully in by the 3rd Friday of the month or 18th of the month for services to start the 1st of the following month. If it comes in after that 18th date, then your service is not going to start until the next month. So like today is 4/22. So if all the paper was in for, an MLTC enrollment because of a good outcome notice, NIAP outcome notice today, the services are not going to start in May. They're going to start in June 1st. For Medicaid managed care, so a mainstream plan that you're already in, that person should contact member services, ask to be transferred utilization review, and find out what is needed to provide, what they need to provide to the mainstream plan in order to receive an hours authorization for home care. This can be really fraught dealing with some of that now with some of my own clients, because a lot of plans also have, mainstream plans may also have MLTC plans. And so you do want to be really careful with a consumer in a mainstream plan, and clear when you're counseling them or working with them through this process, like if they want to stay with the mainstream plan, even though there's a lot of confusion because they don't tend to provide as many home care services because their pool is much larger and most of their enrollees don't have home care. So they often will get confused. You just want to make sure that a mainstream enrollee who wants to stay in mainstream, they can get all of their home care through their mainstream plan. They don't need to be transferred to an MLTC plan if they're able to, theoretically choose an MLTC plan. For the local Department of Social Services, HRA, that's again, New York City, HRA, or CASA, it's the home care unit. The outcome notice, if you're getting the home care, if consumers getting home care through HRA, then the outcome notice has to be provided to the local Department of Social Services or HRA in New York City. There's a central fax number here. HRA will also, similarly to the plans, conduct their own social assessment and then authorize, send an approval notice for a plan of care, including home care hours. Next slide, please. And so we come to hopefully one of the most useful parts of the presentation, which is the practice tips for the NIAP assessments. Oftentimes these practice tips really make a difference for whether or not you get an outcome notice that finds the consumer eligible or not for home care. Next slide, please. NIAP assessments routinely and improperly deny MLTC or PCS CDPAP eligibility because of some built-in ways that they ask their questions and assess functional kind of eligibility, like ADL, how people meet or don't meet the ADL requirement. So you can expect that these will be problems in the assessment, for your clients or the consumer, and that you should be prepared to address it. Next slide, please. So for applicants without dementia or Alzheimer's disease diagnosis, make sure those consumers or applicants are specifically pointing out to an assessor at least 3 relevant ADLs. So it should go without saying that the consumer needs to be honest. They need to be honest about what ADLs they need help with. This isn't about saying, pick the 3 and then make something up. No, it should be honest and accurate. But it's about looking at that list of ADLs that was listed on that previous slide a couple slides ago and seeing which ones apply to that consumer. And you really specifically want to identify those ADLs that the consumer needs at least limited assistance or guided maneuvering of limbs, physical guidance without taking weight, even contact guarding, hovering, that fall into that category. For applicants with a dementia or Alzheimer's disease diagnosis, they need to be prepared, or somebody who's with them during the process should be prepared to point out at least 2 relevant ADLs with which they need at least supervision or cueing. And it's really important, to really put in and utilize that language too, so it's extra clear to the nurse assessor, this idea of they need limited assistance, they need extensive assistance, or if they have dementia or Alzheimer's, they need supervision and cueing. You could be like physically, they could dress themselves, but they need supervision and cueing to pick out the right clothing in order to know where to put their arms and legs and to which direction, all of these sorts of things. Again, this is the form. This might be the first time actually we have a link to the form in the slides. So here it is. This is the Alzheimer's disease or dementia form that's needed to be completed and signed by a doctor before the first assessment. It should be faxed over. And here's a link to the form. Next slide, please. Our other huge tip that really makes a difference is there is what we call the 3-day rule in the NIAP assessments. The nurse assessor, so again, this is that community health assessment, the first one, the long one, with asking all those questions about the ADLs the consumer needs help with. The nurse assessor is expected. This is not the nurse assessor doing something wrong. This is actually them following the rules of the NIAP program. They're expected to look at actual performance of ADLs in the last 3 days, not capacity to perform ADLs. And this very often undercodes a patient's needs or the applicant's needs. So what does that mean? Next slide, please. So that means that the assessor only records the person's actual level of self-care support actually received in the last 3 days leading up to the assessment. That's it. They don't record what they think the consumer should receive or what ADLs the consumer could do for themselves, or they think, the ADLs the consumer could do for themselves. This means that only a consumer has help in the 3 days leading up, sometime in the 3 days leading up to the assessment, that first CHA assessment, is found to need ADL assistance. And this help could be paid or it could be family. It doesn't matter. It's just they need the consumer going into this when they're doing the NIAP. It's really crucial that they have somebody help them at least one of the 3 days before the assessment, and specifically focusing in on the ADL help they need, not just the IADL, the shopping, cleaning. Those IADLs, we're focusing on the ADLs. So for example, we have an example here of Jose's daughter visits to help him bathe twice a week, by physically getting him in and out of the shower. But when the NIAP assessor visited on Monday, the last time the daughter helped him bathe was the previous Thursday. So since this was not within the last 3 days, the assessor remarked activity did not occur and the ADL doesn't get counted towards the minimum. I mean, it didn't occur because he wasn't able to do it, but it wouldn't get counted. Deeply unfair, but this is how it's structured. Our second example, Maria bathes by herself, but it's extremely risky because she bathed by herself, despite, the high risk of a fall and injuring herself. The nurse would mark her as independent with bathing. We do have, a fair hearing that rejects this characterization, but it's really, I'm not really sure how successful we would be with going with the fair hearing approach to challenging this. And so it's really, I think, a more effective use of time for most people to just at least try to get somebody to help them at least with their ADLs in at least one of the 3 days before the CHA assessment for the New York Independent Assessor. And to be clear, it doesn't need to be the whole day. It could just be a couple of hours, however long it takes, just to assist with at least, that 2 or 3 ADLs that the consumer can identify that they would need help with. All right, next slide. So prepare in advance for the assessment. Have someone stay with the client in the days leading up to the NIAP. Have someone also present at the assessment with them. And especially encourage the person who stayed with the client in the 3 days leading up to the NIAP to be present for the assessment. You can also request, again, there's a right to request an in-person assessment, as that could be, give the nurse assessor a fair picture of the person's ADL needs. So what if the NIAP denies MLTC or PCS, CDPAP enrollment? A couple of steps you can do. You can get a copy of and review the NIAP assessment by contacting these emails or fax numbers. You can ask for a redo. That means ask for a new NIAP. Oftentimes this is honestly the fastest way. For example, if you didn't know about the 3-day kind of look back issue, or that they're only looking at the help you actually received, then when you did the first NIAP, then a redo could definitely be a option to successfully get a pass or get a better outcome letter for the NIAP process. If the consumer has dementia or Alzheimer's, then submit the dementia form with a cover sheet and request that they reconsider. And you can also request a hearing from the New York State OTDA Office of Administrative Hearings, just like any other Medicaid fair hearing. Note that there is a 60-day limit, though, from the date of the notice to make that request. Here is, and you can also get the evidence packet. Here is how to request a fair hearing against New York Independent Assessor. Again, because we'll share the slides, feel free to look this up in greater detail if needed. Next slide, please. And so one last practice tip about legacy status. So remember that those who received home care prior to September 2025, they have legacy status. And this means they can continue to access services under the prior eligibility rule, which only required one ADL. And so in case just in case this could apply, especially for someone who's having trouble meeting that 3 ADL or 2 ADL requirement. Just make sure it's always good practice to get the client's home care history to be sure that the correct eligibility criteria for the NIAP is being applied. And you can also always reach out to us here at FLRP and NILAG for further assistance with that. The legacy status generally, right, is you have somebody who has legacy status if you're in MLTC plan or receiving PCS or CDPAP from a mainstream plan or the local DSS. Again, that's HRA in New York City before September 2025. That means enrolled in MLTC or Medicaid Advantage Plus plan as of August 1, 2025, or authorized for home care by the local DSS or the mainstream plan before 9/1/2025, or you're assessed by NIA between 8/31/2024 and 8/31/2025 as eligible, and you enroll in an MLTC or authorized by a mainstream plan or the local DSS within 1 year of the assessment. This is because the NIAP assessment is valid for 1 year. All right, next slide, please. Here are some additional resources on the 3 ADL requirement for the NIAP. Next slide, please. And here are some additional links to the state guidance implementing the ADL limits and the ADL rules that were issued in June before they were rolled out in September. Next slide, please. Okay, so before we get to the immediate need, were there any questions?
I've been answering questions as we've gone, but there are a couple that I wanted to raise to you that were interesting and maybe need a little bit more background. So a really good question. Is the NFLOC score the nursing facility level of care on the outcome notice?
Peter, I don't think so. Yeah, I was like, I've never seen it on the outcome notice.
No, it's not. I agree that it's not there.
Yeah, I've never seen that.
It's
You
on
can
the
do a little bit of deductive reasoning, because if the client is approved for PACE enrollment but denied MLTC enrollment, then you can assume that their NFLOC score was 5 or higher. But it's not listed there. You would need to go and request it from NIAP, as Wenru explained how to do. And then another question is, what is an evidence packet?
An evidence packet is what the agency or the plan, whoever the fair hearing is against, literally submits to the judge, the administrative law judge, which is the judge for the fair hearing, as evidence. So, it would include, for example, like the assessments, the CHA, the community health assessment, the UAS assessment. It maybe include some other stuff, but that's another way of you, a consumer, being able to access information about, why were they found not eligible. And it's important that if you do have a fair hearing, that the appellant or the representative gets the evidence packet prior to the fair hearing. The ALJ should ask about it. And if you don't have, the evidence packet, that's a reason to adjourn the fair hearing until you do, because how can you be prepared for a hearing if you haven't reviewed the evidence against you or the appellant?
And that is how you will find out the NFLOC score and the specific ADLs that the nurse found that you needed assistance with or didn't need assistance with, and to what level of assistance you needed with each of those ADLs that Wenru reviewed. Okay, I think that's it, and I will pass it along. I think, Peter, you're up next.
Yeah, somebody did ask, though, for me to flash the slide again, so I'm doing that as a courtesy. Okay, so for the rest of the training, it's kind of a picture show, the immediate need application process. And I did it this way because honestly, the process used to be a little bit more complicated. And if I were to find a silver lining to the rollout of the independent assessor, maybe this would be one, in that the immediate need application process is a little bit less demanding on the applicant when it comes to filling out paperwork and getting forms filled out. So the immediate need process only applies for personal care and consumer-directed personal assistance applicants, just like the how the independent assessor is looking at your eligibility for those two services. But for context, like why do we care about this right now? And the reason is the timeline for applying for MLTC services. Because remember, we're talking about the same population that would be applying for immediate need versus enrolling in MLTC. And like if you're applying for Medicaid from scratch to get home care, which we know a lot of folks um, are doing, right? A lot of people who are applying for Medicaid for the first time are doing it because they need long-term care. Um, the process has gotten kind of long, right? So if you let's say you file your application January 1st, under the law, the local district has 45 days to determine your Medicaid eligibility. If they need to determine whether you are disabled, in addition to that, which they might need to do for a number of reasons, but it relates to whether you would be non-magi instead of magi, those terms I introduced way back at the beginning. Then they have 90 days to come up with the full approval. Um, but after that, that would apply to a select group of folks, though. For most of our clients, we're talking about 45 days, but that's still a really long time. And in practice, it can take longer because there might be deferrals where the local Department of Social Services asks for additional information, or because the local district is just really overwhelmed with a lot of other stuff, like rollouts of HR1 provisions, for instance. Um, After that, once you're approved for Medicaid, you would request and schedule your NIAP assessment. Uh, Assuming things go smoothly with the NIAP assessment, which it might not. Also, if you request an in-person assessment, it may not happen right away. There have been delays. I did see a question about that in the Q&A. Uh, we're looking at an outcome notice about, well, ideally 2 weeks later, but probably not, maybe a month later. And then you have to contact a plan to get assessments of what they think your needs are. Um, and then if you sign enrollment paperwork, as Wenru was saying, you have to sign by uh, a certain deadline to get for enrollment to start the first of the following month. And there was a question in the chat about this too. I don't actually know that it's been written anywhere, like what the precise day of the month is that you would have to enroll. I have heard anywhere from the 18th to the 21st.
It
Um,
was the third Friday.
yeah, I
That's why
think
it's
it's some,
posted,
yeah,
right?
yeah, but like that changes. So, like that's why your question was very on point, and that's why Wenru was also correct. Like it's it's just not well defined. But big picture, it's not like you can enroll the last day of the month and start services the very next month. You are potentially waiting 6 additional weeks if you enroll too late. Uh, so in this scenario, which is an ideal scenario, you are still waiting 4 months, January, February, March, April, 5 months to start your home care from the date of application for Medicaid, which is horrendous. A lot can happen in that amount of time. The immediate need process, uh, on paper, is supposed to take like 2 weeks tops, and and that includes if you are seeking a financial eligibility determination. And they have to figure out both at the same time. Like these timelines run concurrently. So um, both your financial eligibility and your home care eligibility. They have to figure out your financial eligibility within a week, and they have to figure out your eligibility for home care in 12 days. Um, that uh, has had it's had, what's the phrase? It's waxed and waned. It's ebbed and flowed. Like the in the last couple of years, I've seen the timelines shift, sometimes for better, sometimes for worse. I want to say right now it's about a month at HRA. I don't, that may not be accurate. But it could take even longer if the patient is seeking immediate needs CDPAP because they also will have to onboard their aides with the single fiscal intermediary PPL. So there are potential wrenches here, but still that is way better than 5 months, right? The immediate need application is this is sort of a long list, but these are all forms that are pretty short, unless the patient is applying for Medicaid from scratch or needs to update their I'm sorry, not update, upgrade their Medicaid coverage to include long-term care. And as I said, CDPAP would have an additional step because they have to sign up with PPL. There's the info to submit the application. And then one other point before we start looking at forms, the NIAP in the immediate need process, there 2 or 3 years ago, there was this phenomenon where HRA was, I think, rejecting immediate need applications because people had already gone through the independent assessor. The state issued guidance in 2014 clarifying that as long as the independent assessment is still valid, which, as Wenru said, is 12 months, um, the the uh, the application for immediate need home care should be processed, but HRA will need the outcome notice from the independent assessor because they have to look up the case in the uniform assessment system, which is both a document and like a cloud system. Um, so and that's a lot of people have their assessments there, so it's helpful for them to see like when the assessment was actually conducted. Um, the outcome notice, if you don't have it or can't find it, can be requested by asking for the full independent assessor packet at this fair hearings email address. I use this all the time. You don't need to have a fair hearing pending to use it. And the turnaround time on document requests from this email address is maybe a week and a half now. It used to be much quicker, but a week and a half is still pretty good. Okay, so if somebody needs to upgrade their Medicaid, remember I said that the Supplement A has a description of the levels of coverage and what you need to document. So if you know somebody has Medicaid, but they don't have enough coverage to qualify for home care, they will need to complete this form and prove that they have the requisite, that they meet the requisite asset limit. And there's some links at the bottom of this slide for the application forms. There are also facilitated enrollers available to assist with this. The application has a transmittal requirement, and the transmittal is not substantive in the sense that it has nothing to do with your patient's eligibility. It's really to, when the eligibility worker at HRA gets the packet, this is what tells them what to do. They are trained to look for this. I also really like this form because if you zoom in toward the bottom half here, it tells you what you need to submit. This has not been updated though for the independent assessor. This form is from 2016, so it does have errors, unfortunately. Like you do not need an M11Q any longer for the immediate need application, but you do need, I think, everything else. But each row tells you what you need. Like if you're just looking for home care, you need everything on this top line. If you need to upgrade your Medicaid, but you have Medicaid already, and you're just looking for the upgrade, this second line, and then the final line tells you if you don't have anything and you're applying from scratch, send us all of it. Um, the next document that's important is the attestation of immediate need. This is such a silly form to me because it's just you're saying I need help right away. There's also a section if you're trying to get out of a nursing home. There are other attestations on here, though, like I don't have coverage to provide home care, I'm not getting home care, uh, adaptive equipment isn't enough, and I don't have adequate uh, voluntary informal support. Instead of the M11Q, uh, that's really been replaced by the independent assessment, um, but the practitioner, the doctor, still needs to sort of support the request, and this is the form to do it. Again, very simple form. This shouldn't scare your doctor off. It can be completed by a doctor, an MD, a DO, a nurse practitioner, or even a physician assistant. So that's also great. It's pretty versatile. Then there's an authorized representative form. This is, I know it says New York Medicaid Choice at the top. I promise you, this is also for the New York Independent Assessor. This link on the left goes directly here. And this is if you'll need somebody to speak on your behalf during the independent assessor or during the independent assessment or speak to the NIAP call center. So if that's you, I mean, especially if it's somebody who has dementia, you might want to include this with your application, along with the form for patients with dementia that Wenru talked about in the assessment. A HIPAA you should also include so you can talk to people at HRA. And then just a note on what the NIAP outcome notice will say if you are seeking services from the DSS. That includes immediate need. Also, if you're seeking services from a mainstream plan. It'll say whether you meet the ADL criteria and whether you're medically stable. Those are the two cornerstones of an outcome notice. And you'll also note that there's nothing about needing home care for more than 120 days because that is a requirement to enroll in an MLTC. Of course, after you're done with 120 days of immediate need home care, then you can be assigned to an MLTC. So many of you probably know that rule. The rules do start to line up. There are just so many of them. Consumer is responsible for informing the DSS or the plan of the outcome notice. Yeah, so that's annoying, but there is no real care coordination about any of this. You are responsible for the components of your application. Okay, the plan. So when Rue talked about do-overs, there's also a do-over where the plan or the DSS can ask for it if they disagree with something about the assessment. That is called a variance. A consumer has no right to request a variance. You can only lobby the plan or the DSS to do it. Okay, and if you're not eligible, you can request a fair hearing. And that's it.
Perfect timing. Okay, good. Please close us out. I wasn't sure if there were more slides, but this is perfect timing. We have 1 minute to go. So if you just want to close us out, that would be great.
Come to our next webinar, please. It's a follow-up on this. It'll cover navigating requesting services and asking for appeals. I will also talk a little bit briefly about the ICANN program and how the ICANN program can assist you with appeals. And my colleague Anna Maria will join to talk about appeals as well. She's on our fair hearing team with Wenru. And that's really it. Reminder to join our newsletter. If you are referring somebody to our intake, there's the contact information. And if you're seeking other legal services, especially if you're outside of New York City, lawhelpny.org is a great resource. So thank you, everybody. I don't know if anybody wants to, do you want to try some questions or just?
I think that we've been answering them as we go. We will be posting the webinar onto YouTube. We will provide a copy of the slides and we will do our best to take this question and answer that we've had during the webinar. and share it with the group as well. And just a big thank you for everyone who was able to attend today. Wenru and Peter, excellent job. You're getting lots of accolades in the chat. All right, take care, everybody. I'm going to end the webinar now.